and Sanjay for inviting me to Pune to be part of this really exciting meeting. So as Rita said, I would like you all to shift gears and move into a completely different area of diabetes, which is gestational diabetes. And the talk that has been assigned to me is strategies for prevention. And I thought I would take this whole talk in this direction. First, we know that over 75% of diabetes itself is preventable with education and empowerment. One of the really key things that you can see here is prevention of gestational diabetes and screening for GDM and the strategies for it. The best thing you can still do for diabetes is keep people from getting it. This is something I read in Medscape just in May 2017, and I think it is so true. And the agenda for this talk will be, in part one, I thought I'd talk about the scope of the problem, how big it is, and the consequences of having gestational diabetes. In part two, why do we need to prevent this? And part three, are there strategies for prevention? And four is really how can we get our girls and women fit and ready for pregnancy so we can prevent gestational diabetes. So the first thing is the definition of gestational diabetes itself is changing a little bit. We always thought of it as onset or first recognition of abnormal glucose tolerance during pregnancy. But what I want to mention here is in the new WHO recommendations, what they've talked about is that it's a distinct entity that's diagnosed in the second half of pregnancy. And why they've said this is we are picking up a lot of women who in the first trimester or in first booking, we're finding that they're having abnormal glucose values. This is not gestational diabetes. These are people who are walking into their pregnancy with some form of glucose intolerance or some form of dysglycemia. It could be pre-diabetes, it could be metabolic syndrome, or it could actually be frank diabetes. So we kind of have to make a distinction between these two entities. The first one is scope of the problem, and as you all know, the Diabetes Atlas now says 1/4 of all births are affected by high blood glucose during pregnancy in Southeast Asia. And the data from India is as high as 16% published data. So 1 out of 6 pregnant women has gestational diabetes. And just to put it in perspective, we are having so many million births, 147 million births per year in the world. And if you look at developing countries, it's 10 times more than the developed countries. And most of these problems of diabetes and gestational diabetes are happening in the low and middle income countries. And to take a deeper dive, and I want to show you what's happening in India. Last year alone, we had close to 27 million births. If you have 27 million births, that's more than the population of Sri Lanka. And if you have 16% of the pregnant women developing gestational diabetes, just do the math and you can see the number of people having gestational diabetes. And 50 to 60% of these women, 5 to 10 years from the intense pregnancy, are going to develop type 2 diabetes. So this number is just going to snowball into a really big number. And what are the risk factors for gestational diabetes? Because we are talking about prevention of GDM. So you look at the risk factors, and I have highlighted the important ones, which are body mass index. So overweight and obesity clearly linked with increased risk of GDM. Family history of diabetes clearly linked with risk of gestational diabetes. Previous GDM, increased risk of GDM, future GDM. And then there are other things like polycystic ovarian syndrome. Birth weight of the mother. The lower the birth weight of the mother, the greater the risk of gestational diabetes. And then her mother having gestational diabetes is a risk factor. Certain nutritional deficiencies, carrying, maternal age, physical inactivity, ethnicity, all of these things, and also there's some link with vitamin D deficiency and hypertension. All of this seems to be risk factors for gestational diabetes. The next question is, why do we need to prevent GDM? And these are the main reasons. Number one, children who are born to mothers with gestational diabetes are at increased risk for future type 2 diabetes. And they get the type 2 diabetes at a younger age. So that is something to keep in mind. Women who have gestational diabetes in one pregnancy are at much higher risk for GDM in subsequent pregnancies. That's the second risk. The third one is there is risk of overweight, both generalized obesity and visceral adiposity in the offspring of mothers who have had GDM. And more recently, we have data to say that cardiovascular risk is increased in mothers who have gestational diabetes, more than the risk that is imparted by type 2 diabetes alone. Just GDM alone increases the risk for future cardiovascular disease. And just to show you that the prevalence of impaired glucose tolerance in the offspring of diabetic mothers is at a very young age, 10 to 16 years, and even at 5 to 9. So we are setting up a stage for a large cohort, a huge burden of disease in the future in children starting at a much younger age. And I also want to show you what's happening with this whole NCD risk in mother and corresponding NCD risk in her first offspring. So if the mother has gestational diabetes in the first pregnancy and then in subsequent pregnancies, look at the trajectory of highest trajectory. So we should really look at pregnancy as a window to future chronic disease. That's a really important thing to start looking at gestational diabetes and preeclampsia and preterm deliveries and small for gestational age babies as high-risk pregnancies, and mothers who have had these complications are at future risk for chronic disease, non-communicable disease. So we really should keep an eye on them. And the same thing is happening to their children. So these are all the really important reasons why we should think about preventing GDM. And then the other really important thing is that they are at much greater risk for future type 2 diabetes. This is all Indian data and postpartum screenings. And one of the big study from Chennai, which I was part of, showed that as much as 20% of the women have some form of dysglycemia within the first 1 year. And this whole diabetes and life cycle in women, and I want to show you, if the baby is born small, either because of long-standing pre-gestational diabetes or maternal nutrition or other reasons, or the baby is born large due to gestational diabetes and macrosomia, so we're going to have a baby who's already at risk for future diabetes. Then this sets them up for childhood obesity, sets them up for adolescent obesity and polycystic ovary syndrome. And young working women now have a sedentary lifestyle, and urbanization and globalization are setting them at risk for diabetes. And you can see what is going to happen to them when they become pregnant. They're definitely going to go on and do gestational diabetes. And as adult women, they will have type 2 diabetes. And diabetes in women carries much higher risk, as I always like to mention, that it's different and difficult, more heart disease, more stroke, increased risk of higher mortality in women. And are there strategies for preventing all these things? And let me show you. This may not be the more positive part of the whole talk. We must optimize the birth weight of the baby. Not too high, not too low, optimum birth weight. Maternal nutrition, we must pay attention to maternal nutrition and proper weight gain based upon either the IOM guidelines or the FOXY guidelines. Correction of things like hypothyroidism and nutritional deficiencies. And very, very important that we do a postpartum follow-up of these women. So these we know work for prevention of future gestational diabetes. Now, what about, and then we also know about intergenerational programming, and I want to stress upon the importance of baby's birth weight. The first 9 months, the pregnancy shapes the future of the child for the rest of their life. And prevalence of diabetes during pregnancy, according to the birth weight of the mothers. So if the baby is born small or the baby is born large, like I mentioned, increases the risk of future gestational diabetes. So this postpartum follow-up that has been recommended is a really simple thing. 6 to 12 weeks after delivery, they need to come in for an OGTT are normal, we still prescribe lifestyle modification and then follow-up testing probably either annually or a 3-year basis. And then if they have inbuilt glucose tolerance, more intensive lifestyle modification, you keep monitoring their A1Cs, and if they shift into the normal, excellent, continue lifestyle modification. If they move on to diabetes, we intervene at that particular point. So this postmortem checkup is a key thing towards future prevention of type 2 diabetes. Other strategies that are being looked at are nutritional intervention during pregnancy, physical activity intervention during pregnancy, vitamin D supplementation, and things like supplementing chromium and probiotics, ioinositol. So just to give you this forest plot of the meta-analysis of all the RCTs in terms of diet interventions and a mixed approach of diet and lifestyle and nutritional supplements, you can see that it's not a super optimistic slide that I'm showing. That really don't see a big benefit in any of these interventions. Overall, it just seems to do no major prevention of GDM. The short answer is, if the woman has already become pregnant and we start intervening at that particular point, it may be already a bit too late, so we need to start thinking about preconception care is the message from all of us. But let me quickly show you some studies. But when they look at subgroup analysis, either the women who are obese or moderately obese and intervention is done to them and the weight gain is restricted to the recommended IOM weight gain, there seems to be some trend towards benefit. One of the largest studies that came out recently was the radial study. Gestational diabetes can be prevented by lifestyle intervention. It's a little bit misleading because these are all women who've already had GDM. This is prevention of GDM in the next pregnancy. So the conclusion was a moderate individualized lifestyle intervention reduced the incidence of GDM by 39% in high-risk pregnant women. And high-risk are people with previous GDM. These findings may have major health consequences for both mother and child. And this is really important too, because if we are going to have 16% of people with GDM and they go on to have another pregnancy, we can at least try to decrease the amount of GDM in the next pregnancy. And what about the diabetes prevention program? Diabetes prevention program also showed that women who have GDM go on to have higher risk of type 2 diabetes than the women who did not have a history of GDM. And when they intervene with either metformin or with lifestyle modification, we know what happened to the people who did not have GDM. But for the people who had GDM, metformin seemed to work better than in the people who did not have GDM. Still, lifestyle modification is always very good. But if that is not working, metformin is an alternative for people who have had GDM. What about other nutritional intervention studies? A primary prevention of gestational diabetes through nutritional factors, a systematic review has been done, and what they found was all the observational studies collected showed that achieving a healthier dietary pattern, such as a Mediterranean dietary pattern, and lowering of certain foods with high heme iron content and other things like sodas and potatoes, could possibly reduce the incidence of GDM. Especially again and again, they keep talking about the high-risk population and before getting pregnant, as you can see from here. So in this systematic review, they found that the majority of the interventions done during pregnancy are not effective in preventing GDM, although there were cases where supplements seem to be beneficial, and I'll show you that. The evidence is very scarce. There was another study called the WAKE-UP study, which was a pragmatic control trial to prevent childhood obesity in maternity and child health care clinics. This again restricting weight gain during pregnancy and watching pregnancy and infant weight gain outcomes. Again, they looked only at high-risk GDM women. High-risk for GDM women, either BMI over 25, previous macroscopic baby, or age over 40, or family history of diabetes. And what they found was the intervention group had fewer pathological oral glucose tolerance test results. So this is one of the few studies that showed that in high-risk people, if you intervene very strictly and limit their weight gain, probably we could decrease the risk of GDM. And another IDEC study, which is a primary prevention of GDM and large gestation age by lifestyle counseling. This was a cluster randomized trial, and again, what they were able to show is only in the high-risk population. Now, what about physical activity and fitness benefits? We all know that physical activity will positively impact upon glucose metabolism, on blood pressure, lipid concentrations, and has so many other benefits. And maternal outcomes will be on gestational diabetes and preeclampsia, and possibly even other benefits. And fetal outcomes will be in terms of optimizing birth weight and limiting preterm deliveries. The DALI study, one of the few studies that has looked at both physical activity and nutritional counseling. This is effect of physical activity and healthy eating on GDM risk. This is the DALI lifestyle study. And what they found was they took consecutive pregnant women less than 20 weeks gestation, no GDM by the IDEC criteria, but BMI more than 29. They were randomized to the study. And the women received 5 face-to-face and up to 4 telephone coaching sessions based on the principles of motivational behavior. And they aimed for a gestational weight gain of less than 5 kilos was targeted. In the results, what they found was, let me see if I can summarize the results. So in the results, what they found was, in the healthy eating and the physical activity group, but not the healthy eating or the physical activity alone, the women substantially achieved less gestational weight gain than controls. However, despite this reduction, there was no changes, no improvements in glucose in these women. And then probiotics. This is one good study that was done with probiotics, and pregnant women were given probiotics, and what they found was at 24 to 30 weeks, they assessed whether the patients had regular GDM using 2 measurements, the IDEC criteria and also the New Zealand criteria. There was an overall lower rate of GDM in patients who received the probiotics as opposed to the ones who did not. So this is something to keep in our mind. Could have some future benefits, but as of now, you probably will have to just recommend nutritional probiotics, which is simple yogurt. Vitamin D deficiency and GDM, there seems to be a connection, but in terms of studies looking at replacement and preventing GDM, we do not have hard data yet. So the best thing would be to optimize their vitamin D levels before they get pregnant, because we cannot use especially high dose vitamin D in the first trimester. What about myo-inositol? Only one study, myo-inositol supplementation for prevention of GDM in obese pregnant women. This was a randomized controlled trial. When it was started in the first trimester, seems to reduce the incidence of GDM. And we know that myo-inositol is present in nuts and seeds and grains. So the good thing would be to recommend those things to our pregnant patients till we have more data that comes out. And again, this I think could be a promising intervention for prevention of GDM. So the Cochrane review basically says, ideally future studies should consider involving women from different ethnicities, different risk factors for GDM, and it would be useful for future studies. I do feel this probably has some potential. Which brings us to, so what can we do to prevent GDM? We've talked so much about how much of GDM we have, how risky it is to have it, and what are the serious consequences, and all the interventions that we talked about. Really, there is nothing that is clean saying this prevention is great, we don't have anything. The short answer is nothing seems to be dramatically preventing GDM. So what can we do? What we can do is get our girls and our women, before they get pregnant, do a preconception care, and that is the only thing really that is going to decrease the risk of gestational diabetes in all populations. And there are some studies that are coming out about preconception, pre-pregnancy physical activity, pre-pregnancy weight reduction, pre-pregnancy proper nutrition, actually decreasing the risk of gestational diabetes. So keeping this in mind, we in Chennai have launched a program called Fit to Be Mom, which is a tool that we are putting out to the young women in the marriageable age, and also women who have just got married, or women who are planning a pregnancy. And this is actually a simple 20 see screening for diabetes is an important part of this triple program. And the engagement model is we do it through physicians and OBGYNs, we do it through individuals, we do it at workplace, we do it in schools and colleges, and we have now formed something called as a bridal coalition, where brides go to jewelers and salon people and cosmetics and salons and wedding planners and that whole coalition, and see that every point of contact, if we can empower young women with knowledge about preconception care. And we have to invest in our adolescents and young people because there are 3 billion people, young people under the age of 30 on the planet today. 50% of India's population is under the age of 25. 65% of India's population is under the age of 35. So we have to invest in this population if we want to prevent gestational diabetes and have decreased risk of future gestational diabetes in terms of transgeneration transfer of diabetes. But I also want to say, when you pay attention to all this, it's not just that this person is not going to get diabetes in the future or GDM in the future. Everything about this person changes. Their education is better, they marry at the right age, they have the right amount of children. But overall, this is upliftment of the entire society. So on that note, I want to thank you for your patience.